Postductal sats for cardiac conditions. Preductal, right hand. Just remember R has R and right. You're going to be correct. Right hand sat. And then also check a sat in the leg. If you're seeing a difference of more than 3 or 4%, or if you're having less than 90%, consider a cardiac lesion. Okay. And then there's this hyperoxia test. You may hear about it. It's falling out of favor for the most part because O2 sats are so reliable. But what it is, the old school version of a hyperoxia test, place a kid on 100% FiO2. Put them on an every breather. It's about the best we can do in the ED. For 10 minutes, and then we're going to check an ABG. What we're looking for is if our PaO2 is less than 150, we probably have a cardiac lesion. Reality is checking an ABG in a little baby who's critical, not doing well, pretty fiddly. Okay? You can get most of your information from these pre- and postductal sats. Okay? But if you're asked, that's what we're going to want to do. Now the poor man's hyperoxia test, put them on that non-rebreather, check their sat. If they're getting up to 100, probably not a cardiac lesion. If you're not seeing a big change in your oxygen, that's when you need to start worrying. Do some more stuff. Check an EKG. So EKGs in kids, I think, freak a lot of people out. EM folks love to focus on the T waves. Not a whole lot of reason to focus on a T wave in kids. Just remember this. When kids are born, all the T's are up. A week later, they all flip back down, and then they start flipping back up again. The T waves in V1 through V3 will often remain flipped through adolescence. That's normal. Don't worry about it. But what we're actually going to focus on in the early period, especially these newborns that we're concerned about in congenital heart disease, is hypertrophy. So we're looking for right ventricular or left ventricular hypertrophy. In the right side, it's defined as an S wave in V1 greater than 98% of the predicted height in that age child. And then, the R wave, and then the S wave in V6. So R in V1, S in V6, and the opposite for left ventricular hypertrophy. Remember, if you think about fetal circulation, all newborns are going to have right ventricular hypertrophy. That's normal. Don't worry about it. But if it persists out of the neonatal period, that's not normal. And left ventricular hypertrophy is never normal. So if you're seeing signs of left ventricular hypertrophy, you're going to have a cardiac problem going on. Do some more stuff. Get your x-ray. Lots of clues that you can pick up. Black lungs, not a lot of pulmonary vascular markings. Maybe you have a right-sided obstructive lesion. Cardiomegaly, big heart. Maybe you're shunting or you're having some hypertrophy. And then your cardiac silhouette, your boot-shaped heart here at the top. Your eggs on the string, all the things you heard about can give you clues as to what's going on. All right, so case 1, our little 5-day-old, it's blue. Are we going to give prostaglandin? Heck yeah, we are. So we're going to be worried about a ductal-dependent lesion, so we want to give prostin early to these kids. 0.1 mics per kilo per minute to start, and you're going to look for an improvement in your oxygenation. Do you want to give them oxygen? Yes. Be careful though. Our kid was satting 30, you're going to throw some oxygen on them. Just remember, oxygen is an extremely potent vasodilator. You could force this kid to over-circulate their lungs. The lungs are a big sponge, they like to soak up blood, and when they're full of blood, they don't work very well. You could make them worse by giving them too much oxygen. Aim for a sat of 85. You get to 85, you're pretty good. And then with fluids, be judicious. We tend to start with 5 to 10 in our cardiac kids and reassess. So this kid, these are old slides, this kid ended up having critical pulmonary stenosis, okay? So his pulmonary valve was very, very tight. You could see this on echo as well. Throw a probe on these kids. Look for that thickened valve, look for hypertrophy, look for poor movement, poor function. These kids are ductal dependent. They need prostin to keep that ductus open while the cardiologist is getting ready to take them to surgery to do a balloon valve valvuloplasty, basically bust open that big stricture valve. We're We're going to go to another case. A 2-month-old comes in with colic, 8 days of intermittent vomiting, feeding well until the past few days. He's having some GI symptoms. Healthy otherwise. Healthy otherwise. There is a family history of this leaky valve. The dad was a Marine. It was pretty healthy. All right. So this kid's a little tacky. He's a little Kipnick. He's satting 80s, mid-80s, but it comes up to 97 after a liter. He's got some crackles. He's got a liver edge and a 3 out of 6 murmur. So this kid, pretty pink. Remember what we're thinking for pink babies? More maybe a CHF type of picture. All right, so we're gonna ask, what color is he? He's pink. Is this kid gonna need prostate? Probably not. He's 2 months old. The ductus tends to close around 2 weeks. We'll extend that up to a month. This kid's ductus is closed. We're not with a ductal dependent lesion. Does he need oxygen? He improved. He got better. His oxygenation improved to 97% with just a liter. And then are you going to give this kid fluids? Maybe. But be gentle. 5 to 10 and reassess. This is this guy's EKG. Anybody seeing anything abnormal here? So we're seeing some cues, some pretty deep cues, We're seeing a couple of flip T's. If this kid were 45 years old and I handed you this EKG, would you guys be worried about anything? Maybe. This is the X-ray. You seeing anything concerning here? A little fluffy, a little pulmonary vascular congestion. So what does this kid have? There's a little clue here. So this kid has CHF due to Al-Kappa. Not alpaca, Al-Kappa. What the hell's Al-Kappa? It's the anomalous left coronary artery off the pulmonary artery. So you have this really dumb coronary that's supplying deoxygenated blood to the heart. Not good. Most of these kids present in the first 1 to 2 months of life. I've seen it at a week. I've seen it at 42 years. So you will get adults with this. There is a population of these patients that build these awesome collateral circulation, and they can go for a long time, years, without being recognized. These kids are often mistaken for colicky babies, refluxy babies. Keep your suspicion for something else open. These kids need surgery. They basically remove that dumb coronary and they put it where it's supposed to be. If you checked a trope on this kid, it'd be high. Yeah. They're having an ischemic event to their heart. Just remember, in kids, CHF is quite different from your adults. Especially in infants, these kids have difficulty feeding. They're slow feeders. They get sweaty. They get angry. They cough. They gag. They spit. They're often small. They have failure to thrive. They have big livers, cardiomegaly. So remember, feeding in an infant is the equivalent to your stress test. So if your kid can't feed, something's wrong. So always ask the family, how are they feeding? How long does it take them to drink a bottle? If you're going like 40 minutes to drink a couple ounces, that's not normal. Think about a cardiac issue. For management, pretty similar to your adults. Remember, don't force them to have a normal SAT. If you're getting to 85%, be pretty happy with that. Kids can tolerate a lower SAT than adults. Be judicious with your fluids, and if they're overloaded, give them diuretics, just like you would an adult. Give them Lasix, 1 per kilo. And if they need more support, milrinone or dobutamine is a good choice. Case 3. All right. So a 6-year-old comes in. He has a hypoplastic left heart syndrome, and he's had a fun tan. He has nausea, vomiting, diarrhea. He's a little tacky. He's setting 73. He's febrile. He looks dry. His eyes are sunken. His lips are dry. He's tachycardic, weak pulses. Well, first of all, ask, is he older than a month? Yeah, he is. He's a big kid. What color is he? He's a little blue, a little gray. A little bit of both. So first question, what the heck is a Fontan? So I want to just review very quickly. Stages of palliation for kids with single ventricles. They do it in 3 stages because when they tried to do it all in one, the kids died. So they go in 3 stages. The first stage is the Norwood or the VT shunt, typically done in the first week of life. Followed several months later, a little bit before a year, with a bidirectional balloon, also known as a hemifontan. And then several years later, preschool, 2 to 4 years, they're going to get a full fontan. So the Norwood, stage 1. So this is for a hypoplastic left heart only. Remember, these kids, they don't have a left ventricle. Therefore, they're going to have a crappy aorta as well. They have these little atretic aortas. So they're going to rebuild that. Aortas are important. So let's get them a good aorta. Then they're going to clip the PDA and give a Blalock-Towsing shunt, typically from the SVC to the pulmonary artery. Think of this as a man-made PDA, a man-made conduit. These kids are satting 75 to 85%. This is followed by, the Norwoods, just remember, they're unstable. They're being kept alive basically by this 3.5 millimeter shunt. Be careful with these kids with oxygen and be careful with fluids. This is followed by the bidirectional blend at 6 to 9 months. They're actually going to take down that little Blalock-Towsing shunt, that VT shunt, and they're going to attach the SVC straight into the pulmonaries. So they're going to have some passive blood flow to their pulmonaries. These kids are also normally setting 75 to 85. And then finally, they're going to get a fontan. The IVC is going to be attached to the pulmonaries. Okay? So at this point, they should be setting pretty normally. Now there are many iterations of this. There's extra cardiac, there's all these different conduits, there's fenestrated, there's unfenestrated. But the big thing to remember is that these kids have passive pulmonary circulation. There's nothing pumping blood to the pulmonaries. So these kids are pressure and volume dependent for their pulmonary blood flow. Okay? These kids do really well. Their survival is about 82% at 20 years, so they're going to grow up. A lot of them will have learning difficulties. They've lived at these low saturated levels for a long time. Okay. But they do have problems. Okay? Again, pulmonary blood flow is passive. It is volume and pressure dependent. So dehydration is bad. Hypotension is bad. And increased intrathoracic pressure is bad. Our patient was dehydrated. We're going to want to give this kid volume. Okay? I actually had this kid the other day. Gave him 10 per kilo. His SAT improved. We started getting more blood flow to the lungs. Okay? 10 per kilo, reassess. If you need to get more, give more. Okay? Make sure their pressure is normal. Get them normotensive. All right. These are my old slides, so we're not going to go through that. These kids do get arrhythmias. They also are at risk for clots as they're getting older. Just remember, with your fluids and all these cardiac kids, 5 to 10 per kilo, go slow until you need to go fast and then go fast. For our fontans, remember, this is the repair of a univentricular heart. Pulmonary blood flow is passive. It is volume and pressure dependent, and they do get arrhythmias. In general, don't try to make your SAT 100 in these cardiac kids. Okay? It's a potent pulmonary vasodilator. If you get to 85, be happy. Leave them alone. Be gentle with your fluids, and those kids under a month, give them Prostin. 0.1 mics per kilo per minute. Remember, they can become apneic. It happens in about 12% of patients. Be prepared if you need to take their airway. All right, that's all I have for you guys.
I don't know if you can see in the back, but this guy is going to be difficult to oxygenate. So